All right, let's get back. Chapter 32, the patient with nicotine use disorders. We used to call it in the previous text the patient who uses tobacco. Well, nicotine comes in many forms now, not necessarily just tobacco. So it's nicotine use disorders, and it's chapter 32. You are going to be having patients who will freely admit that they smoke or they use nicotine products. Others will not, but they will have the oral signs that they use it, especially certain types of tobacco like the snuff or the chewing tobacco. You will be the first one to see the oral implications of that well before the patient or even the physician. So it's important for us to really recognize the patients who do use tobacco, what the health hazards are. We know what they are. The patient knows what they are. Okay. But what are some of the components of tobacco products? There are a lot of toxins. It's not just tobacco that's in there. We can identify alternative tobacco products. Some are healthier than others, and explain the mechanisms of nicotine delivery with these alternative tobacco products. We need to know about the metabolism of nicotine and what it does to our system, as well as recognize the oral manifestations of tobacco use. So, it's not just the person who uses the tobacco, it's also the people around them, the environmental tobacco smoke. They're even doing studies now where the vaping, the cloud that comes out of the patient's mouth and lungs, is that having any effect on the people around them? Develop a dental hygiene care plan for the patient who uses tobacco, and recognize the protocols for developing tobacco cessation program, and identify pharmacotherapies and behavioral therapies used to treat nicotine addiction. So you have one tobacco cessation skill evaluation that you have to do before you graduate. And the earlier you can get that out of the way, the better, just because you can get it out of the way. But hopefully your oral hygiene binder that you made has a small section in it on tobacco use, and you can take the patient through that. There are a lot of online resources as well. I have a tear sheet that I posted on Canvas that walks you through everything you need to know and do for your skill evaluation. But it's one of those pre-made things. You have the patient pick a quit date, and you take them through all the various steps. And if you can find that and have it ready for anybody at the last minute, you will have everything you need for tobacco cessation skill evaluation. It's just a one visit skill evaluation, which doesn't make any sense to me because there's no follow-up for it. So let's get down to the nitty-gritty. Tobacco is toxic to humans. I don't know who smoked the first of whatever. It always amazes me. But tobacco use is the single most preventable cause of disease and premature death in the world. Preventable. Approximately 25% of the Americans report using some type of tobacco product. There are all sorts, from hookah to pipes to cigarillas to cigars, but anything combustible or chewable, smokeless. The offspring of smokers are more likely to become smokers themselves. And as years of tobacco use accumulate, so do the systemic and oral effects of the form of tobacco. Their life expectancy is shortened. Millions and millions of Americans suffer from disease caused by smoking. And about 90% of men and 80% of women who die from lung cancer, it's attributed to smoking. Now, you always hear about patients or family members or relatives, whatever, that never smoked a day in their life, but they died of lung cancer. So there are different forms of cancer out there. But patients know it's not good for them. They know. What we have to do is let them know that we're here to assist them when the timing is right. But nicotine is the drug in tobacco that causes the addiction. And these tobacco companies have done a lot of research to enhance that addiction. If you are addicted to it, you will come back and need to buy the product. Um, McDonald's and fast food chains and the food industry does the same thing. Let's add more fat, let's add crispiness, let's add sugar, even though it's not a sweet. French fries aren't sweet, but let's add sugar to have them want to come back. So I don't smoke, but I got my own addictions. So nicotine is considered toxic, and about 60 milligrams can cause death. And that I've seen on the boards. 60 milligrams can cause death. Once tobacco is ignited, then you've got these carcinogenic substances that become part of the mainstream smoke that are emitted, as well as secondhand smoke. Cigarette smoke can have about 7,000 chemical compounds going on. Over 90 of the chemical compounds in tobacco products and tobacco smoke are identified by the FDA, Food and Drug Administration, as being unsafe or having an unsafe potential. So they are categorized as carcinogens, respiratory toxins, and cardiovascular toxins, reproductive and developmental intoxicants, as well as a combination of all of those. It is very addictive. Is anybody doing a paper on tobacco? Their group paper? We used to have to do, did the paper, and then we would make you, because I had to do it too, do a table clinic where you would have to do an oral presentation and have oral and visuals up, poster board and that type of thing. We don't anymore. So let's talk just a little bit about the metabolism of nicotine. It is absorption of the nicotine occurs through the body's membranes. You've got, think about the membranes that the smoke and tobacco is going to be in contact with. You're inhaling it. It's your lungs, your skin, your oral mucosa, your buccal mucosa, the nasal mucosa, as well as the gastrointestinal tract, the GI tract. So the delivery method affects the way the nicotine's absorbed into the body. Are you inhaling it, or are you chewing it or having it tucked in your mouth? It's very acidic as well. The more basic the medium is, okay, whether it be the smoke or the smokeless tobacco, the easier the absorption is. So a cigarette or a pipe smoke is less acidic than cigarette smoke. So what is going to get the nicotine into the body the easiest? It's going to be the cigar smoke. The same thing goes true with the smokeless tobacco. So nicotine is the addictive carcinogen. Mostly it's absorbed through the lungs. and it passes into the arterial circulation by way of the blood vessels and the lining and the little sacs in the lungs. It goes to the brain. Nicotine's delivered efficiently to the brain by the bloodstream in less than 20 seconds. Peak plasma concentration. If you look on 34.2, it illustrates the peak plasma concentration from various tobacco products, as well as the nicotine replacement therapies. Those patches all have nicotine in them, trying to wean the addiction. So following the onset of smoking, the peak plasma concentration of nicotine occurs in approximately 4 to 5 minutes. So the patient who smokes gets an immediate gratification. It takes 20 seconds for it to hit the brain. Peak plasma is 4 to 5 minutes. The nicotine spread throughout the entire body. It's metabolized in the liver. And that's what you got to know about nicotine. Then you've got your smokeless tobacco products, which is also called snuff. It can be moist or dry chewing tobacco products. Has different names on it. There was a commercial way back when I was young. The Winston Salem, they had commercials, and it was just a pinch between your cheek and gum was for the smokeless tobacco. Just a pinch between your cheek and gum. I still remember that. So the smokeless tobacco is placed in the mouth, and the amount of nicotine absorbed is 3 to 4 times the amount delivered by a cigarette. 3 to 4 times the amount. The nicotine concentration declines over about 2 hours, and it can last up to 24 hours as it declines. After 24 hours, it's dissipated through the system. But smokeless tobacco users experience nicotine blood plasma levels similar to the nicotine blood plasma of smokers, but it's at a much greater concentration. It's absorbed through the intestines. Most of that tobacco juice that's in the mouth that's produced by smokeless tobacco is spit out, but not all of it. Juice that's intentionally or accidentally swallowed by the user is absorbed through the blood vessels and the lining of the small intestines. So, smokeless tobacco. Plasma concentrations. You've got your patch. Some patients are wearing a nicotine patch because they're trying to come off of smoking. So you're still getting nicotine. Then you've got your gum, your lozenge, the green inhaler, nasal spray, moist snuff, and cigarettes. Plasma concentration, cigarette, up very high, and then it starts dissipating. Has the highest peak. You also have the electronic nicotine delivery system. That's not what this is here. This is a hookah. We called them water pipes when I was younger. My father spent a number of years in Iran, and he would get water pipes, and we have all sorts of artifacts that he collected over the years, and he had to get rid of them. This was in the 70s when it was just a water pipe to him or a hookah, and my siblings discovered it could also take marijuana in it. So they were smoking their marijuana in it, and all of a sudden the water pipes disappeared from the house. Interesting. There are electronic nicotine delivery devices, e-cigarettes. that is being found to have even more detrimental effects than smoking. There's something called popcorn lung, that this smoke, the vapor gets into all the arterioles, and it disforms them. So the patient can have more breathing problems long term from using an e-cigarette. And here we thought the vaping was going to be better. Okay, it might be better because they don't have the secondhand smoke that they're dealing with and the other things, but it's still just as bad in different ways. The side effects are obvious. You've got your cardiovascular diseases. Smoking aggravates and accelerates the development of atherosclerosis. Coronary heart disease is a leading cause of death for Americans, not necessarily all due to smoking, but it's clumped in there. We've got pulmonary diseases, COPD, chronic obstructive pulmonary disease, chronic chronic bronchitis, emphysema. Smoking is responsible for about 87% of the lung cancers. And it's not just lung cancer, but that is the leading cause of death among smokers in both men and women. Used to be higher in men because men smoked more than women. But smoking can cause different types of cancers: lung cancer, larynx, throat cancer, oropharynx cancer, esophagus cancer, trachea cancer, stomach cancer, liver cancer, pancreatic cancer, kidney cancers, bladder cancer, cervix cancer, and colorectal cancer. All have been related to smoking. Smokers are also more likely to consume alcohol, and the two together works symbiotically, so the harm is greater than just smoking or just drinking. Smoking and drinking together creates even a worse effect. Now, I was born in the 1950s. We knew that smoking was bad. My mother knew, but it was the thing to do. My mother had 5 children. I'm one of them. And she smoked and drank through all 5 pregnancies because there wasn't the stigma of smoking during pregnancy or drinking during pregnancy. We didn't really know about drinking back then. But luckily, I came out quote unquote normal. That's still debatable by my 4 brothers, but that's okay. That's for Thanksgiving discussions. So, environmental tobacco smoke. You're not smoking, but guess what? If you have somebody around you that smokes, you are having the similar effects of the smoker, especially kids. Oh my goodness, they are relating all sorts of things to children. So, you want to be careful on who and what you allow to be smoking. A lot of the smokers are now relegated to going outside of the house. So the house is not filled with smoke, and you're trying to protect your loved ones from smoking if you smoke. Some offices will not hire employees that they know smoke. The patient doesn't want to smell smoke on you. And it's very hard to do as I say and not as I do. But a lot of it is the smell also. If you are one that smokes, some people don't have that smoke seem to cling to them, and others do. So some hygienists that smoke will only smoke after work hours. Environmental tobacco smoke can be just as deadly to loved ones even before they're born. So review this. Okay, there are fetal heart defects that have been linked to secondhand tobacco smoke as well as the mother smoking. They have here socio-demographics. What do you think that means? Socioeconomics, the low income population is less um, has less healthcare available to them, and oftentimes it is income related. Yes, um, they have less healthcare afforded to them, less literacy in healthcare is afforded to them as well, and some of it is just lack of knowledge. But the lower income tend to be more smokers during pregnancy. Environmental and behavioral risk exposures, self evident maternal pregnancy history. Again, I had one child when I was smoking, so I can have another child when I was smoking. They came out fine. But it's not always. We don't see these things oftentimes in infants and newborns. Some they're relating learning disabilities to smoking as well. Not only the maternal smoking, but the secondhand smoke. Oral manifestation. Think about barbecuing your mouth. Low and slow. Barbecue has got a low heat, but smoking isn't necessarily a low heat, and it's for a long period of time to tenderize that meat. All right, we're doing the same thing when we smoke. So the pattern and severity of the clinical presentation really vary with the frequency and duration of tobacco use and the type of tobacco use. So when we ask on our medical dental history, do you smoke? We always follow up with the type and then how much and for how long. I smoke 2 cigarettes a day is for 50 years is going to have a very different oral effect than I smoke a pack a day for 2 years. So we are doing an intra-extraoral exam, and we can oftentimes detect first something that's going on inside the patient's mouth. I had one patient who came into me and I was updating the medical history, and I have done EOIOs and blood pressures. I pride myself on it since the day I graduated from dental hygiene school. And he came in for his 6 month cleaning. He was overdue, and I'd been seeing him for years. And I asked what changes in his medical history. Has he been hospitalized? He had throat cancer, esophageal cancer, and was operated on. And my heart literally just fell into my stomach. I'm thinking, oh my gosh, I've been doing cancer screenings on this man every 6 months, and I didn't catch it. I looked back in my notes, I didn't have anything. So upon questioning him, how was it discovered and everything, he was having blood in his stool. And when they investigated that, it was coming from his esophagus. My hue was, it was below where we could see. Okay, you know, you say, you do all this other stuff. So it was farther down than that. But blood in his stool took him to the doctor. And they were able to diagnose esophageal cancer. Was he a smoker? No. Just one of those weird things. But we know, and we're educating our patient. We're not just saying we're just checking for lumps and bumps. When we're doing an oral cancer exam, we are saying we are doing an oral cancer screening. 4% of the cancers show up in the head and neck area before they show up in the body. So the mouth is literally the gateway to the body. So we're doing a service for the patient. We don't want to minimize what we're doing and what we're performing for our patient. And we don't want to minimize our education either. We are doing a cancer screening. We know that oral cancer, okay, shows up in areas of the mouth, predominantly the lateral borders of the tongue, the floor of the mouth. I mean, and that's what we're checking. So we're talking to the patient while we're doing this and we're educating them. Effects of the periodontal tissue. We are baking our periodontal tissues. Baking, we are causing vasoconstriction. We are causing fibrotic gingiva, thick, leathery gingiva. They are not going to present themselves with periodontal disease in the same way as a non-smoker. A non-smoker is going to have the beefy red gingiva. They're going to have bleeding on probing. They're going to have very friable tissue that kind of flaps and tears easily. It's thin. Versus a smoker is going to have a thick, leathery tissue that doesn't bleed. So the bleeding indexes might be 3%, but they could have 7-8 millimeter pockets. Smokers do not respond well to non-surgical periodontal therapy. They don't respond well to surgical therapy as well because they don't have the circulation. So that's why with the implants, when we were talking last week, the implants, they want you to stop smoking for at least 2 weeks. To me, that's a little bit conservative. 2 weeks to get that circulation going again. So if you have a smoker that you've done your root debridement on, you're not going to see a big change in the pocketing, especially on that palatal tissue. I don't know what it is about that thick palatal tissue. That pocket just never wants to resolve. But you're doing what you can. You're lasering, you're putting the Arrestin in there, the minocycline. You are doing what you can. The patient stops smoking. In between visits, the next time they come in, they're bleeding all over the place because their circulation is coming back. So their response to treatment, if they're a smoker, is not good. Nicotine addiction. Okay, you've got a tolerance. I used to be able to do 2 cigarettes and I'd get my nice little high from that. Now it's taking me 4 cigarettes or a pack. Okay, you build up a tolerance the longer you use it. So the patient, if they're looking for that hit, that nicotine hit, they're going to have to smoke more and more. Okay, and that increases the dependence on the product, and that is all built into the product. The companies want you to be addicted because you are then a repeat customer. The patient really needs to have a reason to quit. You cannot tell them they need to quit. You can. Are they going to listen? No. Until they are ready, they're not going to. They know it's bad for them. They know they're creating issues with their loved ones with the secondhand smoke, environmental tobacco smoke. They know that. And a lot of smokers need to be try and quit multiple times before there's long-term abstinence. So you can go cold turkey. I just stopped. That's hard to do. You can reduce the number of daily tobacco exposures. So you can have, especially for the engineers population, I'm going to make a spreadsheet. I grew up with engineers, so it's always about a spreadsheet or something, a table. But when do you smoke? What are your triggers? Well, I always smoke as soon as I get up. I smoke after every meal. I smoke when I'm in the car. I smoke, there are certain things. I smoke when I'm upset. I smoke because I can take a break and go outside of the building. And if I don't smoke, I feel guilty taking a break. So there's lots of triggers that you want to try and address. They have found that smoking and having a buddy really helps. So, what does the patient want to do? Do they want some sort of alternative, nicotine alternative, to lessen the withdrawal symptoms? Because some patients can get headaches and can get agitated very easily. So it all depends on what the patient thinks is best for them. And many of them have tried all sorts of other things. So self-help interventions, what can the patient do? Well, you can distract them. Okay, well, instead of smoking when you first get up in the morning, why don't you try brushing your teeth first thing? Brushing and flossing. Well, then my coffee doesn't taste good. But you can come up with alternatives that the patient is involved with. And that's the whole thing. Even with oral health education, your OHE skill evaluation, the patient needs to be involved with these. We can tell the patient exactly what we want them to do and why, but if the patient doesn't buy into it, it's not going to work. Have them be part of the solution. Let the patient know that you and the doctor and the staff, everybody's here to help you when the time is right. We're here. Just let us know. We've got a lot of strategies we can help you with. Just let us know. You don't need to beat them up around it. Because a lot of things combine a combination to be successful. One of my best friends going through hygiene school when she was pregnant with her first one, this was after hygiene school, but she said, this is going to show me how, she was a smoker, and she said, this is going to show me how selfish I really am. If I can't quit because I'm pregnant, I don't deserve to have this baby. Now that was pretty harsh. And she was able to quit, and she quit for good. But we are there to help. And part of that help is using pharmacotherapies to help treat the nicotine addiction. So instead of going cold turkey, you can wean off, okay? And there's also other medications that can help with just that addictive personality. And dentists are able to prescribe these. Many of these used to be just by prescription. Now they are over the counter: nicotine gum, nicotine patch, inhalers, nasal sprays, lozenges. The important thing with whatever the patient, if the patient wants to decide to try one of these systems, is they have to reduce their smoking while they're doing it. Remember that 60 milligrams of nicotine is lethal. Well, even before that, they can end up with headaches and heart arrhythmias and other things if they're having too much nicotine in their system. So if I'm not reducing the amount of smoking I normally do, but I've got the patch and gum working with me, I am putting even more nicotine into my system. So they have to be withdrawing from whatever tobacco use they're using if they're augmenting with one of these replacement therapies. So they need to take that into consideration. And there are other medications that can be prescribed. Have you gotten into bupropion, sustained release, or bupropion in pharmacology yet? No. Okay, well, you're going to be getting into this. This is Wellbutrin. Wellbutrin is an antidepressant, but it's also been found to work well with addictive personalities. no matter what you're addicted to. It could be alcohol, it could be food, it could be nicotine. It doesn't matter, but they are finding that a certain dosage of medication can help with that. So this was the first non-nicotine medication shown to be effective for tobacco cessation. Usually take it about every 8 hours. All of these can be used with other strategies to quit smoking. Then there is the varenicline, I can't say that, tartrate, and that is a medication also to be effective. That's usually taken after meals with a full glass of water. It can induce nausea, which is a deterrent for smoking. So that's where the water comes in. You want to smoke, you're going to get sick from it. I don't think I'd take that medication. Then there are lots of combination therapies along with the patch and the gum and everything. And what the patch does and the gum, they take you through stages. So they'll start you with a higher level of nicotine absorption, and then you wear that for a couple of weeks, and then you go to a lower dose and a lower dose and a lower dose. Now with the nicotine gum, you place a piece of gum in your mouth and you just kind of keep it tucked. And when you need that hit of nicotine, you bring the gum out from the little tuck in the mucobuccal fold and you chew it to release that nicotine, then you tuck it back in. So the nicotine gum is not chewed like regular gum. Okay, it's just kind of held there until you need it. I remember my mother in the 60s was trying the nicotine gum, and she said it tasted so bad she needed to smoke a cigarette to get the taste out of her mouth. For you, the hygienist, the majority of smokers state that they would like to quit, but are they ready? I would like to lose weight. Am I ready? No. Am I busting out of my clothes? Yes. Don't judge me. I'm not ready to give up stuff that I want to eat yet. Not ready. But when I am, it'll happen because I've been thin before. Just like non-smokers have quit before, and some of them have quit for years before they started smoking again. So let the patient know that you are there to assist them when the time is right. We're not doing anything really different with our smokers. Everything's the same. Your office might have a specific tobacco cessation program that they like using. There are self-help groups. There are used to be something called smoke enders back in the 80s. Smoke enders was very popular, and it was kind of like it was a self-help group where people would come together, and one of their strategies was that the patient, they had meticulous oral hygiene because you were constantly brushing and flossing and using mouthwash. And for them, for some reason, it was the cinnamon mouthwash. And because evidently brushing and flossing and swishing with something and smoking a cigarette is similar to trying to drink orange juice after you brush your teeth. Just doesn't do and feel and taste the same. So if you keep your mouth in that constant state of whatever that taste is, evidently you're less likely to want to have a cigarette. I know a lot of other areas of the world, when they come to the United States, they don't like us because they're not allowed to smoke anywhere. It's not one of those cultural acceptances anymore like it used to be. So they're finding that they are being ostracized, any smoker is being ostracized because you have to go outside, you can't be around the building. But we are there to help the patient in all things. Motivational interviewing. Do you remember that what that is? From the very beginning of DNH 141, you want to instill confidence in your patient. So you're asking open-ended questions, not just yes, no questions. Open-ended questions, you're really getting them involved in their strategies for treatment. What do you think is going to work for you? I mean, for my strategy, it could be for every pack of cigarettes I don't smoke, I'm putting whatever the money is I'm saving into a jar or a bucket, and then I'll go out and well, with me, it'll be going to a restaurant one of these days, but it'll be doing something that I want to do, pleasurable for me, from the money I'm saving from not smoking. Motivational interviewing. What do I want to come up with? What strategies do I want to come up with? And the same thing is with OHE, with your patients. What are the goals they are going to have between now and next time they come in? They decide. You can guide them, because especially if they're sitting there going, duh, I don't know, you can give them suggestions. The 5 A's, you got to know about it. Ask, advise, assess, assist, arrange. The 5 A's. Test question, board questions. And your flow chart shows you how the 5 A's can be incorporated into a clinical setting. So this is something that some students will print out and have in their binder. Ask, advise, assess, assist, and arrange. Ask. You even ask adolescents and children, do you smoke? Do you use any tobacco products? Does anybody in your house use tobacco products in front of you or in the car? Environmental tobacco smoke. Advise. It's good that you're not using. Don't start. Assist. We are here to help you. Let us know when you're ready. There are lots of help out there. There's even internet and app help. That same way with OHE. There are apps that will remind you to floss and brush, just like there are apps to help the patient come off of tobacco. Lots of things online. And in private practice, it's really important to follow up. They have set a quit date. Okay, I want to wait till after Easter or after the holidays or blah, blah, blah. Okay, fine. You write down the quit date. Guess what? You put that in the computer, and you're going to either text or call that patient to let them know you're thinking about them. You chose this date as your quit date. I just wanted to let you know I'm thinking about you and wishing you all the luck, and I'm here if you need me. The whole office needs to be involved. When I was a new hygienist, my doctor allowed smoking in the office. I was working in 2 different offices. Both offices allowed smoking. It was horrible. And we weren't wearing gloves. Become an advocate. And of course, we document. Any questions?
Misty,
Yes, ma'am.
I had a question that's not related to 142. It's related to perio.
Yes, ma'am.
I'm a little confused. Can you just tell me the difference between scaling and periodontal debridement? Because to me, when I read the definitions, it kind of sounds the same.
Well, it is kind of the same.